Actually, I am the director of the Dole Institute, and this is one of the really special nights when I get to introduce the program and then sit back and enjoy the discussion. So let me thank all of you for coming out. Let me remind you to please, right now, turn off your cell phones. I try to be lenient when I'm director and on stage with cell phones, but Claire, she could be really tough on you. So you don't want your cell phone to go off. And I think everybody, if you've been here before, you know how questions and answers go, but I'll explain that again. At the end of the discussion between Claire and our two guests, we will have a student worker or two in the audience who will have cordless mics. Please raise your hand, get their attention. Don't get Claire's attention or mine, get the students with the mics. And please, and they will bring the mic to you, and that's so we can get the audio on our video that will go on our website and that's going out streaming. Please ask only one question and no filibustering allowed. Now, one of the things that I did when I came to the Dole Institute, I wanted to build a student culture that would really give the students here a great experience. And we've tried to build that in many ways, to opportunities for them to network with political leaders, political practitioners, journalists. They get to have some interesting meals with these individuals, and sometimes they get interesting meals like tonight, which were chicken tenders. So, but we also do regular SAB meetings that Claire coordinates and chairs, and we do, as most of you know, every semester an SAB program, and the Student Advisory Board picks the topic, recruits the speakers, and runs the program, and they do such an outstanding job. So anyway, that's why we're doing this program tonight. That's why I'm out here first, why you don't get a young, impressive student. You get stuck with me tonight, but I'm going to turn it over to an impressive student. Claire Michkowski has been with the Dole Institute for, I believe, all 4 years. Mm-hmm. And she's worked here for, is it 3.5? Wow. And she likes to tell the story that the reason she's a member of the Dole Institute, SAB, is because her mom signed her up for it. And we know it's a lot deeper than that, but she's doing a great job with the Student Advisory Board this year. We're delighted that she could step up and be our coordinator. Please welcome Claire Michkowski. Claire?
Hi, everyone. Thank you so much for being here. Thank you to Dr. Freeman and Dr. Umbehr for being here. I was hoping you guys could both go ahead and introduce yourselves and talk a little bit about your backgrounds in the medical field.
So, I'm Josh Freeman. I have a little bit of a cold. I'm a family doctor. I have been for many decades a family doctor. And while I'm retired now and living in Arizona, the last 15 years of my work life, I was the chair of the Department of Family Medicine at the University of Kansas Medical Center in Kansas City. Before that, I've worked, one of the things you get to do if you're old is work in a lot of places and still have it be for pretty long times. I worked in Chicago, Tucson, San Antonio before I came to Kansas in different kinds of roles, mostly involved in teaching of residents and medical students, as well as patient care and research. I can tell you more. I mean, you had a long time to talk about, but it's what's relevant.
Go ahead.
Excellent. My name is Josh Umbehr. I'm born and raised in Kansas, and I went to K-State for undergrad, so I feel more comfortable in purple. Last time I was on KU campus was for graduation from KU Medical School, though. So we're a house divided. We can cheer for both teams, football and basketball. I did my family medicine residency training at Wesley in Wichita, and then we started an innovative program that we'll talk more about. But I'm a big believer in the free market and how we can combine that with healthcare to solve a lot of problems.
Okay, thank you so much. The first question I have for you is actually a kind of loaded question. What's wrong with our current healthcare system?
Well, I can start with that. I think what's wrong with our current healthcare system can be seen by looking around We have a lot of people who don't have access to health care or the health care that they need, some not any health care at all, unless they show up in extremis in the emergency room, and then they get saddled with big bills. A lot of people are uninsured even now after the Affordable Care Act, although fewer than before. We spend an enormous amount of money as a country on health care, or things that we put in the bucket of health care, over $10,000 per capita, which is far more than most countries spend, and at least twice what most other developed capitalist countries spend on health care per capita. And our outcomes are worse. And our outcomes are worse in terms of infant mortality, maternal mortality, life expectancy, frequency of disease, and they're not related to people's habits. We smoke less than a lot of other countries. We have more doctor visits than a lot of other countries. We have fewer than others. We have fewer hospital days. So we have a sort of screwed up healthcare system, which I'm sure we'll get into, but I believe that a lot of that is that huge amounts of that money is not being spent on healthcare for people, but is being spent on making money for people involved in the industry.
I'll disagree with a lot of that. Now and through the next hour, hour and a half. I think what's wrong with the argument we keep having, the discussion we keep having, is these stale, mostly academically dishonest type of arguments that we're really good at repeating, but this logic fallacy of argumentum by repeating. Just because we say it a lot doesn't actually make it so, doesn't make it accurate or relevant. So we spend more on GDP than any other country. True. In context, we spend more on everything than any other developed country because we have more money. So we spend more on entertainment, on insurance, on homes, on cell phones. So just to say that isn't, it's accurate but not sufficient to explain what's wrong with the healthcare system. To say infant mortality, I was really hoping for better, truer, more honest arguments than that, because that was a World Health Organization study that was so incredibly flawed in 2002 or 2003 that they never did the study again. That the US and Britain are the only developed countries that strictly follow the World Health Organization's definition for an infant mortality. Some countries will say that if it dies within the first 24 hours, 1 month, 1 year, they count it as stillborn. So the fact that we have better track record at tracking these things, if it comes out breathing, it's a birth. If it dies, it's an infant mortality. So we're comparing apples to oranges to grapefruits to things that aren't even fruits now. So if we just keep saying this, and I'll go ahead and beat Dr. Freeman to the punch. Medical debt, bankruptcy, also a flawed study done by Harvard, ridiculous study, said 54% of all bankruptcies. Other more academically honest journalists came back and said at best it was 16%, and most of those patients had health insurance, and the max medical bankruptcy was $2,000. That was the average out-of-pocket claim. So we can pontificate on these old arguments, but if we don't actually get down to the heart of the matter, we're not going to advance the discussion. And I think we can both agree that the goal of the conversation is not universal health care or something else. It's how do we propose a solution for America that work within the confines of our unique system to lower costs and improve access. And I think if we use that as the ruler by which we measure the discussion, we'll be able to advance that cause. So what I would say is the problem with the healthcare system we have is it's government run. Over 50% of all dollars spent on healthcare in the US are spent by the government. The government's not that great at doing anything. Let's take school funding in Kansas, kind of a hot topic, not done very well, very difficult to decide. The post office runs a $6 billion deficit every year. They have a $70 billion unfunded liability for retirement plans, and that's just delivering the mail. Okay, so if we can't do education well under the government in a cost-effective way, we can't do the post office, why are we going to just assume that the government can take over universal control of health care, something as big and as cumbersome as that industry? So I think we actually need to propose solutions that specifically improve access and lower costs.
I would disagree with a huge part of that. First of all, I will say that a stale argument, if you shouldn't shoot your brother, you shouldn't shoot your brother. It doesn't become unimportant just because people have said it over and over again. If something is true, something is true. I wrote a book which got published about 2.5 years ago, and unfortunately, it's still current. At least, I wouldn't change very much of it. The government, one of those kinds of stale arguments is the government doesn't do anything very efficiently. We could dig down into that. The post office is starved for money. The post office, we've all sent stuff by DHL and FedEx because the post office doesn't do such a good job. And now they're trying to compete with them because they need to make money to run. They're not well funded by the federal government. Education is the same issue. We starve institutions, public institutions, and say, see, they're not doing that good a job. Healthcare is a terrific example. Medicare, for example, there's traditional Medicare, and there's what is sometimes called Medicare Advantage. If you're familiar with it, Medicare Part C, where you kick in some money in addition to Medicare, and you get an HMO, basically, running your health care. Well, the overhead for Medicare is something under 3%. The overhead for Medicare HMOs, for Medicare Advantage, is about 9% plus about 4.5% profit that they make. So how do they do it? How do they, and the answer is basically they cherry pick healthier people. If you have a population that's healthier, they're going to cost you less to take care of. So I think that talking about stale arguments, the idea that the government can't do anything is one of those things that we throw out there, but it's just it's not necessarily true. And by the way, you're right about the government spending a lot of money. Whether they control it is another question. But between Medicare and Medicaid and people like I used to be who worked for the state or federal government and veterans and military, and you have about 50% or a little more than 50% of all the dollars spent on healthcare. And if you kick in there the money that isn't paid in taxes because employer contributions to health insurance for their employees is not taxable. Your employee contribution is, but the employer contribution is not, so that's lost tax revenue. Then we would say it's over 60% that's being spent by the government, or per capita, more than almost any other country spends in total. So it's true.
Thank you for teeing me up just perfectly, because another academically dishonest point that you'll hear constantly from this side of the aisle that says, and we should be switched in our chairs, because that Medicare runs at a 3%. The government doesn't run anything that efficiently. They subcontract out to private insurance. Okay, the government isn't good. Ask the Indian Health Services how good the federal government is at running their health care. Ask the VA. Ask the Department of Defense running health care overseas. Medicaid, the MIT, an otherwise good organization, did a study that showed the Oregon Medicaid department got 20 cents on the dollar in value delivered to Medicaid recipients. Most states can show that Medicaid recipients have worse healthcare outcomes than the uninsured. So, but we need to move beyond these arguments that you can hear anywhere and propose solutions that, again, will work for the American healthcare system, which is unique to any other country, and will improve access and lower costs. So what I would like to do is just explain what we do and the reason why we're on stage. So 8 years ago, we started a practice that's now grown to a nationwide movement. Dr. Ryan Newhoffel, a doctor here in town, practices the same model. And it's what we think is actually a feasible solution that fits both sides of the aisle. The only way that you could have a functional single-payer system is to drive costs down. The only way you can drive costs down is with our model. So our model is what's known as direct primary care. Insurance-free practice. We charge a monthly membership based on age, $10 for kids, $50 for adults, for unlimited home visits, work visits, office visits, technology visits, no copays. Any procedure we do in the office is included free of charge. Stitches, biopsies, joint injections, ultrasounds, bone scans, lung scans, Holter monitors, minor surgical procedures, etc. We dispense medications and labs wholesale. So we can get medicines 95% less than you're paying at Walmart. Walmart will sell you 90 pills for $10. I get wholesale 1,000 pills for $8. We've gotten breast cancer chemotherapy from $700 a month down to $6 a month. Walgreens will sell you 30 nausea pills for $120. We get them wholesale for $2.99. We pass those savings on to our patients. We can do the same thing with labs. Blood test to check for diabetes is $2.25. For the cost of one name brand medication for 1 month to control type 2 diabetes, I can get 25 years of metformin a generic medicine to cover diabetes. So now, and we can apply that to labs, radiology, pathology. We decrease ER visits and urgent care visits, which are some of the most expensive types of health care. We also decrease specialty referrals. So we can take all that value, we can apply that to the rule that we've already agreed to for this evening's debate. What will work for the healthcare system and improve access and lower costs. So we're decreasing the cost of primary care significantly. But we can go and work with a small business, because those are the easiest right now under the current legislation, and decrease employer insurance premiums by 30 to 60% in the first year. Some of our employers have decreased the cost of their small business health insurance by 75% over 5 years as they've grown as a business. So if we want an affordable solution for health care, we sort of have it already. And the quote is that the future is here, it's just not evenly distributed. So we can find a way to improve care, improve insurance, improve access, and lower costs. But that's through insurance-free, government-free innovation. We're not anti-government, we're not anti-insurance, we're pro-efficiency.
Dr. Freeman, would you like to respond?
Well, I think that there's a lot of flaws in that argument. I'm not disagreeing with the fact that Dr. Umbehr is probably happy with his practice, and other direct primary care doctors are happy with their practice, and that many or most of the patients who access those practices are happy with them. But it's not a replacement for a health system. And part of the difficulty in understanding this is that the costs are not evenly distributed among people. This is a relatively young crowd, probably a relatively healthy crowd. So you have to understand that about half of American people are kind of rounding error in the dollars of cost. We talk about however many $1,000 it is per capita, most people don't spend anywhere near that. Then about a little less than half use, maybe their share of the dollars. There are people like who are older, who have chronic diseases, go to the doctor several times a year. Maybe they're hospitalized once in a while. And then there's a small percentage of people, about 5%, who account for about 50% of health spending every year. So as long as we can avoid having to take care of those people, we can be a very profitable organization. We can do really well. The problem is those people are out there, that's one. And the other is that they change every year. So who are the people who are high spenders? One is a sort of obvious group, which is those same people who go to the doctor a few times a year, who have chronic diseases, and then they get worse. They have a heart attack or a stroke, and they end up in an ICU, and they have maybe 2 ICU hospitalizations, and all of a sudden those costs are astronomical. But other groups are people with cancer. Some, maybe Dr. Umbehr has done very well on some cancer drugs, but the cancer drugs that have to be administered IV are very expensive, and the care for cancer patients is very high. Another group is people who are in an accident, most commonly motor vehicle accidents, but it could be others in war or through intentional trauma that need multiple surgeries, and all of a sudden they cost a lot. And the other big group is premature babies who are in neonatal intensive care units. The problem is not just that, gee, some of us are really expensive, but those of us who are really expensive change. We may all be in that low cost group, that 50% of people who spend 3% of healthcare dollars, but tomorrow we could find out we have cancer and be in that high-risk group. So or somebody could be in a car accident on the way home and need lots of surgery.
So the problem is, and again, this is a logic fallacy, where he shotgunned a lot of things at you that are true but not relevant to the argument, and we still haven't proposed a solution that is affordable and increases access, which is the crux of the debate. So I'm supposed to be responsible for war injuries now. No, the government does that, the VA and the Department of Defense. Car accidents, your car insurance covers that. Accidents at home, homeowners insurance. But the nirvana fallacy, and this is I find almost unnerving, is that a primary care physician is almost arguing against the value of primary care. Is yes, a majority of people don't make up a majority of the cost, but that still doesn't negate the fact that we have fixed something for them. This is the nirvana fallacy. If you haven't fixed it all, you don't get any credit for fixing any of it. Did I say it was a solution for everybody? No, I said it was a valuable solution that decreased costs and increased access for the people that use it. And we have patients of all income brackets. So it still unlimited visits, no copays, free procedures, meds and labs 95% off, insurance up to 60% off. That's still a huge solution for the majority of people. So then we move to tier 2. So again, I said we're not anti-insurance. I'm not anti-government. Again, if the government is going to come out and effectively be the insurer of last resort, then they have to control costs just like anyone else. The only way for the government to control costs and care is a broad-based primary care workforce, and that's something both sides of the aisle will agree to. So even a universal health care system, the only way they could control costs if they embrace the market. And that's the only true force that drives costs down. So let's take another example. Food. What do we do for people who need food in this country? And arguably we need food way more than we need health care, right? Most people, he said it himself, go to the doctor a few times a year, but we all eat 3 times a day. So when we have people in this country who need access to food, we give them money. And we give them money so they can act like a consumer in the market and use the force of Dillon's and Walmart and Target that have driven the cost of food down, and they can go out and do that. They don't need the government to own the grocery stores. The government doesn't force redundant and punishing paperwork and coding rules on the grocery store. So why are we doing that to healthcare? The goal of insurance is to use it as a tool, and it's a tool to manage risk. And we manage risk, which are big, expensive things that don't usually happen very often. My home doesn't usually burn down, but I want homeowners insurance for it. Why are we using the government to insure medicines that are a penny a pill? Sometimes under a penny a pill. So I can treat your high cholesterol for $3.65 for the year. The government coming in and helping with that doesn't add any real value to that. If anything, if you said, fine, there's a person who needs their cholesterol controlled and they're on a government program, it's still more effective to give them $50 a month, let them buy that service for $3.65 a year for their cholesterol medicine, than it is for the government to send even the stamp and the paperwork back and forth. So we're looking for the most cost-effective solution to get the most people accessible care, affordable care. Whether you're in a socialized or a single-payer, universal payer system, pick your term of choice, they still need to access care. They still need a system in place, and no other system, the Canadian system, the British system, the Germany system, can show those kind of levels of reduction in price. 2 weeks ago, a Canadian doctor was so frustrated that she tweeted out a message, the government scheduled her patients a neurology consult for 4.5 years from the date, which triggered a hashtag trending Canada Waits, where people flooded the internet with stories about how long they're waiting for care in a single payer system. So of course we can't compare Canada to the US because Canada is not the US. But even if we did, that would make the assumption that the Canadian system is working so efficiently that we could copy it here. And that would just be inaccurate to do so.
Dr. Freeman?
Well, there's a lot of fallacies. I mean, I'm not saying that first of all, I'm not saying that primary care or family medicine is a bad thing. It's a great thing. And if we had people more going to family doctors who could manage their diseases rather than self-diagnosing and going, I got a zit, let me go to a dermatologist, we could take care of a lot of things that affect the majority of people. So
Which
I'm
is
a big
exactly
fan.
what we do.
And I have not said that what you do is bad. I don't know that there's enough sufficient data to show that is the best way to go, but I'll stipulate it for now that it works for access to primary care for the people who could afford to pay for it. Unfortunately, some people can't afford to pay for it, and they don't get access. I do object to kind of fallacies that globally say, again, the government doesn't do anything. If you look at almost everything, it's because it's underfunded. When you look at, say, single payer in different countries, and there are different manifestations of it in Canada, Germany, France, England, there are 2 components, which is how do you distribute the dollars and how much are the dollars. So if we could say, well, we distribute it all appropriately, evenly, but we're grossly underfunding the system, you're going to have long waits. One of the things that changed in Britain a number of years ago was they increased the amount of money funding the National Health Service. It's still way less than we spend per capita, but all of a sudden it got rid of most of the weights. And the weights vary. We talked about at dinner that if you remember, since you introduced it, that water kills most people, that in world terms, most of the people in the United States are wealthy. Now, well, it's also true that we have a lot of money that's being spent, but a lot of it is going to not deliver health care. It's for drug company profits, it's insurance company profits, it's hospital profits. We talked about coding earlier, and if you upcode so that you can make more money, that's money that it's great from a market-based point of view. You know, you have a business that makes a profit, but it's money that's in this healthcare bucket that actually isn't being spent on healthcare.
So let's take those three things that we just talked about. This fallacy of arguing the both sides of the argument. America's healthcare system is broken because we spend more on GDP than any other country. So then I suggest to another country, well, Canada and England, well, but that's because they're underfunded. That's why they have problems. Well, which is it, Dr. Freeman? Is it that they're an efficient universal healthcare system that is
It's that you can spend so little that no matter how well you distribute it, there's not enough. But you can spend an awful lot and not distribute it appropriately, and then there still isn't enough.
But you don't get both sides of the argument. You can't
because
say
there's different issues.
They're not. You're talking about percent of funding. And Canada is great because they spend 10% of their GDP on healthcare, and America's bad because we spend 19%. But then the Canadian
I didn't say Canada's good and America's bad. Well, so and you're the one who suggested that we're unique and we can't follow anybody else's model. Okay. What I said is that there's, as in most things, there's a mean. There's a certain amount of money that would be necessary to provide the health care that everybody needs. And if we double that amount so that corporations can make a huge profit off of delivering it, then that's too much. And if we half that amount and we can't provide care for everybody, then that's too little.
So Canada is bad. They have problems with long wait because it's 10%. It's good that they capped it and they're less than America, but if we gave them more money, so if we brought them up to 15% of GDP, it would solve all the problems. It's just a classic government play. Throw more money at it, and Kansas has been trying to do that with the public education system for years, and it still doesn't work. They can show that more dollars spent on education does not equal better outcomes, and so then we both agree, the data.
Who shows that?
The data. We both agree that the healthcare system is inefficient. No one is arguing that. So then if you say, well, if we spend 19% but we're inefficient, great. What did I propose? What we both agreed on was to present an argument for a system, a structure that improves access and lowers cost. So if we can decrease the cost of medicine by 95%, unlimited visits, no copays, free procedures, decrease your health insurance by 30 to 60%, I bet you we can take that 19% GDP and bring it down to, let's say, 15. So Canada would be better at 15, America would be better at 15, but one would be done through a vastly free market-driven approach. So we're in this absolutely amazing building by Bob Dole, and his amazing quote over here, the Senate rules are designed to delay and make things hard. Do you want the same government that it's easier to block something than to do something in charge of your healthcare dollars? Or would you like 50 states doing 50 experiments and 100 companies within each state doing 100 experiments, each fighting feverishly for your dollars? And yes, profit is a good thing.
Dr. Freeman, would you respond?
Whose profit is a good thing? If we have an opportunity to make more profit, we will. We can see hospitals, drug companies, medical device companies taking large medical schools. I don't know. Some medical schools make profit. Mostly those are private.
My six-figure debt to KU would probably say that KU made some bit of profit on that.
Well, you know, you would have to get. I'm not the economist here arguing what's the difference between profit, not-for-profit, and not-for-profits acting like for-profits. Although when you get into a situation where not-for-profits have to compete with for-profits, they end up acting more like for-profits. The difference is they don't pay taxes. So I'm not a big fan of not-for-profits that function not in the public interest, but don't pay taxes.
But we need to propose a solution. What is
and I'm not saying,
solution?
My proposed solution is that everybody's in it together, that we have one health insurance system that covers everyone from birth to death, and that the people with the more resources, I don't mean just financial resources, although that's a piece of it, but education, articulateness, what we generally refer to as empowerment, ensure that it works because they want it to work for them and their families and loved ones, and then it works for the people who are spending too much time trying to work 3 jobs to get by, that they don't have the knowledge and ability to organize the system.
So Medicaid gets 20 cents on the dollar to their recipient, and plenty of states can show the data that Medicaid recipients have worse healthcare outcomes than the uninsured. Dr. Ryan's practice in town has been called the safety net clinic for the safety net, because the patients who can't get access to care at the government-funded clinics show up at Dr. Ryan's and they can pay cash for something because now they're a consumer and they can't get the service they need through Medicaid, so they go to other services. And so Medicaid is not the most efficient way to distribute health care. It's not effective, it's not efficient, it's not affordable. So if we were going to do that, we can both agree that we want to find a system that makes meds as cheap as possible.
Medicaid has its problems. One of the things is, again,
a government
it doesn't pay very
well. See, we do
it's
agree.
not, but we have our government. You've talked about our government. I mean, I'm not sure that our government is in the business of trying to make the government look better than the private sector. In fact, in many of our states, I won't mention any names, we continually have policies that handicap public functions and supplement and augment through tax breaks and direct funding and other things the private sector, because it's a belief that the private sector is better, so we will support it.
I'll argue the exact opposite.
You
that
would,
it's
but
the
you'd
private
be-
sector
I would-
supporting the government, because in Kansas City, the VA hospital, the emergency room, because the state tracks the amount of time the ER spend on diversion when they don't accept patients and divert to other hospitals. And the VA spends more hours every month diverting patients away from their VR than any other private hospital in the Kansas City area. So the government system can't even manage, they're not building a surplus.
But you have to
of
say
care.
why, you can't, to just say it's because it's government is not, the issue is, as we know, and as Bob Dole would tell you, the VA has had its funding dramatically reduced. The people who are in the VA and needing to access service, not so many World War II veterans anymore.
The mystical
because they're
more
mostly
money
gone.
will fix everything.
Well, less money hurts things, and let's talk about that.
No, more
You-
efficiency, because I take less money. I give medicine for less than Walmart does. I compete with the largest retailer in the world that offers pharmaceuticals.
And where do you
I-
get the pharmaceuticals? You
the
buy them from
same-
the drugs.
No,
So-
from the same place that Walmart buys them for, but I'll give them at a lower markup.
Right, so that's your, that is not the place that you make your money. It's the place that Walmart makes it, or Walgreens
Right, and
makes its
Netflix
money.
outcompeted Blockbuster. Blockbuster made $800 million a year, 16% of their profit on late fees. Netflix turned 20 years old September. They started no late fees, and Blockbuster said, "You're crazy." This is Blockbuster. This is Kodak. This is every major organization that said change won't come to us and we don't have to innovate. So somehow providing chemotherapy, 99%, the nirvana fallacy still plays. I haven't fixed anything. But that is still cheaper than what the VA is offering meds. The VA still depends on other groups, and just throwing more money at government programs has never fixed anything.
No, I think that, first of all,
Not to
it's
mention,
wrong.
it robs from the argument that if you throw more money at one thing, it takes money away from something else.
Dr.
If
Freeman,
if
go
we
ahead.
had an organized, which we don't, even government, not to mention, in other words, we could say, we might be able to agree on, that a lot of money is spent in the last few weeks of life on people that doesn't make a difference in them. The problem is two things. One is, I don't know, it's the last 2 weeks of life. And second of all, and this came up a long time ago, if I go to my doctor and say, "Doc, I know I'm dying. I probably won't be here for more than a week. Why don't you stop spending $10,000 a day on me and instead go build some housing for homeless people? Go feed some hungry people." We can't do that because we don't control that money. All we can do is say, let's not spend it on me, and maybe it'll be spent on somebody else. So there is no centralized coordination of how we allocate resources within the health field or across the society. The government is the only vehicle for being able to make those decisions about where we allocate money. Should we spend more on schools? Should we spend more on healthcare? I would say more on both.
So the inefficient government that you just described is the government that you want to be the single payer of the healthcare system, 20% of the GDP. And what I would say is that those same patients can make those decisions. Unfortunately, Medicare does an awful job of explaining it to them because, newsflash, if you die in the hospital with a $100,000 bill, Medicare comes after your assets. So Medicare can suck all the retirement money that you had, anything that you're going to pass on to your family, and take that back to
My
pay
point
off.
was that
So
you can't decide to not use it on yourself and use it to say, there's a lot of hungry people out in downtown Kansas City. Let's feed them for the $100,000 that you don't spend on me.
A true but not relevant statement. Yes, Medicaid recipients can't decide what to do with Medicaid dollars.
And I think that you say the government's always inefficient. It isn't inefficient. You've stated that the overheads were not accurate. They were not, but that's not true. The overhead in Medicare is considerably lower.
How much fraud is there in the Medicare payment system?
How much do providers, hospitals,
$70 billion.
Commit fraud and steal money from the public sector?
The 3% is like $10 billion. So Medicaid counts the $70 billion in fraudulent payments as services rendered. If you've ever run a business, you understand that fraudulent payments come off the bottom line. Those get added to your operating costs, unless you're Medicaid. So Medicaid has fraud over 3 times higher than their actual 3% operating budget.
That's Medicare, 3%.
Medicare, thank you. Sorry, yes, Medicare.
Because they're different programs.
But the fraud is higher than the operating costs, and they put that on the bottom line as part of their revenue, as service. That's how fraudulent the government is. And we have yet to hear a proposed solution to the problem. How do you increase
access? That's not true. You just don't agree with the proposed solution to the problem. The proposed solution to the problem is everybody is in one health care. So we could think of it as an improved and expanded Medicare for all. Medicare has been for people over 65, blind and disabled, so that we all are in Medicare, and we work to make sure that the services are adequate, that the funding is adequate, that money is not wasted.
So how much money will you give to me when I have a medical bill? We're in this together, right? We all agreed with that. Right.
That's why it's not done on an individual basis.
Oh, it's not done on an individual level, right?
It's done as a centralized. Exactly. I could give you $10,
but you won't.
But I won't.
But you
won't.
Do it centrally.
Exactly.
Because you'd rather do it through the tax policy. And the scary part about this paternalism is that it's government control. I'll tell you what to do, and I'll use the point of the gun to make the government tax you, take your money, and it will decide what to do with it. That's the scary part of it, is we're all in this boat together. I don't think the Indian Health Services are happy in the boat they're in. The VA veterans aren't happy in the VA boat they're in. So we're going to take a broken system, and he just said words. Universal health, we're in this together. That's not a proposed solution. I proposed a detailed way of
very detailed, specific way.
No.
One single payer, which insures everybody.
I'm going to cut in here with a question.
What country do we use to emulate? Because we need a detailed response to say, because it's not the England system, it's not the Canadian system, it's not the Singapore system. So what system do we use for a single payer?
Go ahead and respond.
We devise our system, which I would suggest would be expanding Medicare to cover everybody from birth to death, and then working to ensure that this central pile of dollars spent on health care was spent efficiently, providing primary care to everyone, providing curative care to those people who could be cured, not providing elective procedures that waste money and increase risk for people just because they have insurance, that would be, and that the government would pay for it, but not necessarily run it.
So the Medicaid system that's financially insolvable now, we're going to extend to the entire population.
Medicare.
The Medicare system that's financially insolvable. So that's just saying do more of the same thing that's broken isn't a plan.
Well, I think that you don't like the plan, but I say everybody in Medicare, and then I say an improved Medicare, and a Medicare that disabled, because the Medicare that makes sure that the dollars are spent. I mean, right now, if you have good insurance or a lot of money, you can get lots of procedures that your colleagues, not family physicians, will be happy to do, whether you need them or not, and even if they increase your risk.
That's not your call to make. That's not your call to make if it's a private transaction. So what happens when...
Well, that would be the call to make.
All right, I'm going to cut in here because it's actually time for questions. So hopefully there are some questions out there.
Sorry.
Thank you both for being here today. I was wondering if you could go in a little bit into the biases in academia, especially when it comes to funding. If you've seen with your own projects that the outcome of whatever research you're funded to do has to align with certain interests, and how common is that outcome dependent on the funding?
I'd have to interpret the question, unless you want to take it first.
I think there's a bias. The question is there a bias in research grants that if you propose a project that's going to say, yes, X drives up the cost of disease and is bad, you'll get money. If you say the free market is good, you won't. Ryan, I might just because, did you have an answer to that as a PhD? Okay. Public health masters. So what I would say is, one, I don't do a lot of research, but two, I think we see that trend, is if you do pro-government type plans, you're going to get more resources for that. But then there was a landmark study that came out this week that showed the Medicare rules for hospital readmission rates caused more mortality. More people died because of Medicare billing rules that hospitals had to jump through. So Medicare has a long history of not being very good at improving health. So I would say that reinforcing...
Well, if just on the last one, those are rules that were proposed by the physicians who are supposed to be experts in that. So I'm not saying that was not true. I'm just saying that those rules are proposed by physicians, many of whom and their institutions that they work for make money off of doing those procedures. Like the most recent one being...
Physicians didn't change the CMS laws on readmission rates.
So I think that the answer to your question is yes, but not exactly that way. The government, or the NIH, which is the largest funder, will have certain priorities that says we want to look at smoking reduction. But I think that, in fact, as a primary care doctor, as a researcher who's interested in things that will possibly, if they're studied, improve the health of people next week or next month, and are looked at a community level, I think a huge problem, this is my personal opinion, with NIH funding is that it's focused too much on very basic research, most of which, by the nature of that research, won't end up making a big change. And if it does, it'll be 30, 40 years in the future. Yes, we do need biomedical research in laboratories, but we need a lot more of it being done on seeing what is the outcome of delivery of services on populations. For example, we see that about half the people who should be on aspirin, either for prevention of heart attacks or strokes, are not. I pick aspirin, not more expensive drug, because aspirin's cheap. And that's probably not the reason. So the question of why aren't they? Is it because doctors are too stupid to know that it's good? Is it doctors don't recommend it? Is it patients don't accept it? What are the reasons? That seems to me to be a very important kind of question that we need an answer to, and very important research that might actually be able to change the health of the people. And I think that kind of thing that's community-based and clinical is less well-funded. I don't think, I disagree with Josh. I don't see huge political, or let's say the politics go back and forth depending on who's in control of the administration of what kind of research is funded. But on the whole, they should try to be scientifically run, and that's why it's easier when you're dealing with mice and bacteria than when you're dealing with people, because people don't understand it that well.
Next question.
Hi, my question is mostly to Dr. Umbehr, but you can also, Dr. Freeman, address it if you'd like. I know that you've primarily talked about primary care and delivering it really cheaply for $50 a month or whatever for adults, and I don't doubt your ability to do that, but someone like myself has had 3 grandparents with severe heart problems, and I don't have any control over my genetics, obviously, and the marketplace isn't going to change that. So, when I get older and potentially need that secondary or tertiary care, how are you going to address that? Because that can't be dealt with $50 a month.
So first address the ad hominem attack here. Personally, the laughing nature of it's your fault because you have bad genetics in this example, and that's somehow a hit on the free market because we're also profit-hungry animals. And again, it's an ad hominem attack. What we're proposing is a tiered solution. So you have car insurance, but you pay for affordable things, gas, tires, oil. So then you have car insurance for the big stuff. You have cash to pay for food, but you might have life insurance for big things. You pay your rent, but you have renter's insurance to cover bigger losses. We have phones and phone insurance. So what you would do is you would actually be better suited to manage long-term future risk this way, because right now, assuming a $36,000 salary for the course of 30 years and what you'd currently pay for health insurance, if it didn't grow at all over 30 years, and it grows 30% every year, you'll spend $1.3 million on health insurance over the course of your life. So if we could decrease that by half, you'd have $650,000 more dollars to access care, and you'd still have health insurance. So you would have a tiered approach of affordable primary care, unlimited visits, no copays. You could check your cholesterol for $1.85 whenever you want. And watch for those things that are coming up in the future. So better preventative care that's truly cost effective. And you'd have cheaper health insurance each year because now you can manage those risks and only insure the risks that you really need, the rare stuff, the 5% things. So then you could take those dollars, reinvest those, do anything you want with them, but you would still have the cash reserves, the primary care, and the catastrophic insurance to cover you on the back end. So let's not miss that point. We're talking a tiered solution that improves access and lowers costs. But I'm the only one that's really proposed a solution to that. You pay for everything that the free market can make affordable, like food. And then you tier up to a health savings account for more affordable things and regular insurance, catastrophic insurance, which is redundant. All insurance is catastrophic. It's that homeowners insurance isn't for lawn care, it's for when your house burns down. So by the very nature of insurance is, if we make insurance more affordable and more profitable, you'll get actually a better product from the insurance because they'll compete for your dollars. And you see this actually play out with car insurance. Spend 15 minutes to save 15%. E-insurance, built online, designed by car insurance. They're trying to save you money and provide you a better product. So you would actually have long-term, more money in your pocket, more access to primary care, and better major medical insurance.
So first of all, it was a joke, and it wasn't an ad hominem attack anyway. The ad hominem attack is when you attack a person because you're not attacking.
You're attacking me as the representative of the free market.
No, I wasn't talking about you.
Yes.
I made a joke about the fact that he said he has
that the market has abandoned him because he has
genetic
poor
propensity
genetics.
toward heart disease. And of course, that's one of the key things, is that none of us get to choose our parents. None of us get to choose our genetics. None of us get to choose whether the families that we're born into are in the United States or in a place where the water is poor, or whether our parents are wealthy or poor, or have heart disease or don't. And so those are all the hands that were dealt. If some people are in the position of having disposable income, which they can spend on insurance, and if not, put in a nice savings account. And many people are busy trying to put food on the table and pay the rent, and given the choice of doing something that may be important in the future versus meeting today's needs, are not going to be in the position to be able to do that. And that's just the differences in people's circumstances.
But those circumstances are made even worse by poor government action, where health insurance has doubled in cost under the Affordable Care Act. So who's that hurt most, rich people or poor people? Hurts poor people the most because they suffer a proportionally larger burden there. So if we can lower the cost of insurance, you let their employer give them more dollars, provide unlimited visits, no copays, free procedures, and meds and labs at 95% less, there's no argument to be made that that's not a better system.
We're going to get to another question. So
whether cash or single payer.
Right here.
First of all, thank both you gentlemen for giving us this very stimulating discussion. Question for Dr. Umbehr. How would your solution address the issue of physician shortage and the cost of medical education that you complained about?
Absolutely, great question. So I would argue that it's a myth, the doctor shortage. The American Medical Association says we'll be short 50,000 to 130,000 family physicians by 2025. Depending on the study you look at, American Academy of Family Physicians did a study that 22% of a doctor's time was spent doing non-clinical paperwork. New England Journal of Medicine did a study that said as much as 67% of a doctor's time is spent doing non-clinical paperwork. So, but we'll take the 22% because it's the most conservative. We both agree that there's waste in paperwork. I mean, that crosses the aisle. So 22% of the doctor's day multiplied across the physician workforce, just for family physicians. Primary care, I think, was the so nurse practitioners, pediatricians, women's health. It would be the equivalent of getting 165,000 full-time equivalent physician employees back in the workforce, just by eliminating 22% of the day that is wasted on paperwork. So we don't really have a doctor shortage, we have an efficiency issue. I've yet to see the government program that comes out that decreases a doctor's regulatory burden. January 1st, more MACRA and MIPS CMS regulation will hit, requiring even more paperwork from the doctors at a lower price point. So that is the current Titanic that is sinking. That is what it will be. It's driving doctors to retire earlier than they might have otherwise.
Hey, I'm old.
We agree, yeah. But for good reason. It's driving up physician burnout. 70% of family physicians meet criteria for burnout. So we actually need a new system that will come along and fix burnout, because patients can't get good care if doctors are burnt out, and they can't get good care if doctors are retiring earlier, not going into primary care, because primary care doesn't look that enticing when you actually see the sausage getting made. Direct primary care is bringing physicians out of retirement. It's keeping doctors in practice longer. Dr. Ryan and I both see it in our practice. Students are coming and saying, I was considering cardiology or radiology or something, and now that I see this model where I get to do home visits and actually cast people and treatment and this broad scope of things and text and email and have a rich relationship with no insurance headaches, that is bringing people back into the primary care workforce. So rough math, we have 300 million Americans and 500,000 docs that could do primary care. That's 600 patients per doc.
Do you want to talk about the medical school tuition? Because he asked about that too. Cost of medical school.
Cost of medical school to me is a cost of doing business. Is it expensive? Yes. Is it not unlike any startup that's going to invest a lot of money? Any profession, a lawyer is going to invest in education. An engineer might invest in advanced degrees. It's more expensive than it should be, mostly because I think it's government run. But it's a manageable debt that shouldn't be, I think, the main issue.
So I'd say that one of the big problems, the American Academy of Family Physicians policy research arm called the Robert Graham Center has done these studies and said, you know, if we look at the country as a whole, there may not be a shortage of primary care physicians, primary care providers, or physicians. But they look mainly at family doctors and other primary care physicians. The problem is they're not distributed. So if you're in Kansas City or in Wichita or maybe in Lawrence, where there's dense populations of people, there's higher percentages of doctors. If you're in rural Kansas or rural anywhere, there's lower percentages of doctors. Sometimes you can say, well, of course, you know, there's like fewer people. They don't need as many doctors. But if you look at the ratios, if you look at it by counties, say, the number of doctors that, not the same number, you know, let's say 2,000 counties are short or 2,500 counties are short, is equal to the number of surplus doctors in other counties. It's particularly true, I'm picking on primary care doctors because that's where the American Academy of Family Physicians have looked at it, but it's actually better for family doctors than for most other specialties, which can't even exist outside of a major metropolitan area. But still, doctors tend to practice in areas that are comfortable to them, and most of them come from cities and suburbs, and with people that they understand and where they will have enough patients to feel like they make money. The more subspecialized that practice is, the more that becomes true. And yet, you could make a good argument that for most specialties, say Johnson County is well oversupplied. But the next subspecialist vascular surgeon or ENT doctor who goes into practice in Johnson County doesn't go hungry. Because in medicine, and especially in specialty medicine, supply drives demand rather than demand driving supply all too often.
Well, but the business model drives that as well. And so an insurance-based doctor has to have at least 3,000 patients to make the practice sustainable. I grew up in a county that had 6 cities, Alma, Wabunsee, Eskridge, Harveyville. None of them had over 1,000 patients per city. I know, because we were the trash man. We can still remember the trash cans. So, so you couldn't put one doctor in any one of those cities and have a successful model. And even more so, in the smaller the town, the poorer the town, the fewer private insurances that you can cost shift and make your money off of. So you're right, a bad business model drives out good money. But now in a direct care model, a doctor can make a full income off 600 patients or less. So we actually see more doctors going out to more rural areas because they were attracted to those regions or those locations for a reason, but they couldn't functionally practice medicine there if they stay under a government platform, not even government, an insurance-based platform that just requires more units. So yes, I'm going to have to move to a bigger city, but now it becomes so hard to be a solo doc because you have every year more regulation to comply with that the only way you can do that is to become part of bigger groups. So bad insurance-based, inefficient, government-driven clinic models are pulling doctors away from rural communities. But I think the direct care model could incentivize them to go back to those communities.
Okay, we have a question over here.
I'm wondering, how can a healthcare system, or should a healthcare system, include preventive measures that address social determinants of health, such as housing, income, education, and personal stability?
So one of the things that Dr. Umbehr talked about before was that we spend more money on everything, but it actually isn't true. In fact, one of the flaws about, not his argument, but one of the flaws about talking about America spends a lot more per capita on healthcare is we spend a lot less per capita on other social supports. What distinguishes the U.S. is almost all that total money of healthcare plus social supports are spent on delivering medical care and providing expensive high-end medical care. So clearly, if you have people who are at greater risk because they're just getting by at the best of times when they're not sick, because they barely have enough food, because they don't have warmth in the winter, because their neighborhoods aren't safe, they're at greater risk. So addressing the social determinants of health is clearly a core part of having a better, healthier country. It's not going to be addressed by a single payer system or by direct primary care, but either or both of those could be components of a healthcare system that is part of an overall approach to addressing the social determinants, all the determinants of health, not just the social determinants.
So let's look at that from the other way. Canada spends 10% because they cap it out. That doesn't mean they get all the health care they need, they just cap their spending. We spend, let's call it 20, just for simple math. So they have 10% more to say, let's spend on the social determinants of health. And they still don't have better outcomes. Because those things are important, but we run just the slippery slope of saying, well, everything's health related, because anything that keeps us alive is health. So entertainment. Well, if you're not entertained, you'll be depressed. If you're depressed, health goes down. Any number of things. So we can't paint too broad of a brush there, but if you had 10% more GDP, an equivalent amount of what Canada spends on healthcare to spend on other things, they're still not getting groundbreaking results there. Those are all valuable things. Those are other functions of the government, but not even functions that a single payer system in England or Canada pays. Canada, one of their biggest topics this month, other than Canada Waits, was parking fees at hospitals. Parking fees have gotten over triple digits per day to park at the hospital, whether you're a patient or a visitor. So now health care might be free when you can get it, but all the other pieces of that are through the roof because the government doesn't control parking fees, so the government's going to control parking fees, and that'll just be another extension of a problem. So it's a very broad topic, and I don't think you'll bring that all back under insurance reform or things. That's education, that's crime, that's clean water, there's just other topics. Better served independently.
Okay, we have time for 2 more questions. There's one right here.
Thank you for being here. I know we're here to talk about payer systems tonight, but when we look at the drivers of costs, the population is getting larger, number one, so there are going to be more people to use care. We're living longer, so we're going to have opportunity to use more health care. And with the technologies that are coming along, all of those add cost to the whole system. So perhaps we ought to be talking about what is the public policy of this nation with respect to who gets care, not just how it's delivered and what it costs, but what is our public policy with respect to people receiving care in America? What should our American population expect of us? You might comment on that, both of you.
I think it makes sense to evaluate the types of care that can be delivered and evaluate the benefit that comes from it, as well as the cost benefit, and the risks of harm that come from it, and take those into account and say, these things work and should be paid for, and they should be paid for in these kind of people. You know, obviously some people, we don't do pap smears in men, for example. That's a clear example, but some people, you know, we know that certain procedures which work for 65-year-old people are not cost effective if we do them for 95-year-old people. And so those need to be evaluated, and those are being evaluated, but they're not always being implemented because our current insurance model, which is private, somewhat regulated, the implementation of what gets paid for is often responsive to what people want and what doctors want to do, rather than the evaluations of what's effective, cost effective, and has a greater potential for benefit than potential for harm. Because there will always, with more technology, more research, be more things we can do. The question is, what's the marginal benefit and what's the cost? And this is where Dr. Umbehr and I certainly agree, is the greatest benefit is going to be in expanding access to primary care and the things that primary care doctors, that family doctors can manage.
What I appreciate in your question, if I had it right, was the implication that there's a limit financially. I mean, the financial physics of it are that we can't spend all that we want on all the people for all the things they might need. Similar to the Kansas educational budget, 100% of the pie is 100%. We have to divide it up among certain things. One, on some level, to agree that yes, there's inefficient care, but that Medicare is paying for, that's not the best use of those dollars. The other side of that is we have a keen sense of independence and individuality in America. And it may not be the most efficient globally if you do a study, but that doesn't mean it may not be efficient at the bedside for this patient. So one patient will say, well, we won't do a hip surgery on you because you're 80, and we don't think you'll live to get the full 10 years of the hip. But I'll get maybe 5 years of my life that are better than having a broken hip, and I might live to 95, because we know actually the number of patients, the very old, are the fastest growing population. So old stats aren't going to blend very well with new developments. So I'm going to go out on a limb here and say you didn't vote for Trump.
I'm not going to answer that question.
I think that answers the question. And what I would say is, as more of a libertarian, I don't want either side in control of how we choose those dollars necessarily, because the same person who is happy to have Trump in office and running healthcare won't be the same person who's happy when the next person from the other side of the aisle is in charge, deciding how we spend those dollars. So we need to pull back and make it something that is more individually run for the people that can afford it. Everything's at a tiered level, so we have the right solution for the right people at the right time. If you believe that, and you do, then it's for the people who can afford it. From going back to tying up the social justice question, I would say, as a simple thing, is that if we decide that this procedure is that people should still be able to choose whether they want something, because you can't answer a question like, if I say, you have the cancer, we could treat it, and if you get treated, you'll probably live another year. Of course, for 3 months while you're being treated, you'll feel really sick and terrible and miserable. You'll be better for a while, and then you'll go downhill. Or we cannot treat it, and you'll die in 3 months, and you'll be okay for a while, and then you'll go really quickly downhill. Now, what's the right answer? The right answer is, I don't know, because it depends on which of those things you value more. And this is where
doing a rational approach is not doing the same thing for everybody, but saying that everybody with the same diagnosis and the same situation should have the ability to choose the same options. Right. And not to say that some people, because they have more money or better insurance, get to choose from a larger set of options, and those people who don't have more money.
There'll always be people who get to choose from a larger set of options. That's because then we're not talking about government dollars trying to fix that. So when we talk about food stamps, do we do food stamps for steakhouses? You know, can you go to the most expensive Italian place in town and have a bottle, $300 bottle of wine with your food stamp? It's food, it's wine, it's good for your heart. I mean, you can make an art. No, we do.
Not the whole bottle.
Well, not at once, but maybe with friends, maybe after a debate. So that we say, well, we're going to try, if we're going to do charity dollars for care, we do want to maximize that. But here's where it gets really funny, is the government doesn't maximize dollars for outcomes, they maximize dollars for votes. Because when Kansas talked about expanding Medicaid to another 150,000 working poor, they talked about adding it to the top of Medicaid voters. What they don't tell you is that Kansas has over 5,000 permanently disabled children that they won't let on Medicaid because they're too expensive. So we have a really weird way. If we want to talk social justice, I'll talk social justice all day long. Because we have children with cerebral palsy and Down syndrome and autism that the state says no thanks. Because you're such a small number of people, you don't vote, we can spend more money on a greater number of people who do. So we do have to have a question of how best to use those dollars, and we do have to come to grips with the reality that there is a limited number of dollars. So what I would propose is direct care, still obviously, but what I want to kind of impress is how this works on both sides of the aisle. Is we really do think people are, you're a patient before you're a member of a political party. Is if you're from the left, you want to take care of more people more often, a laudable goal. And if you're from the right, you have a focus that you realize that we have a fiscal responsibility and just financial limits. The state's broke. Direct primary care, like any good business, comes in and fixes a problem. So we can't double the budget of Medicare. But that would help people who need Medicare. But we could double the purchasing power of Medicare. So if the state really wanted to, if the state's goal, the state's definition of success was helping more people, is that helping more people and requiring all the paperwork, or just helping more people? So if the state's paying $50 for a blood test that I, through the free market, get for $1.65, then we could help more people. A very, left-leaning, supportive solution. The state's paying $400 a month for a pediatric generic seizure medicine that I get for $40 wholesale. So could we help more kids with seizures if we were more efficient in how the state used those dollars? Yes. So does that make the left happy? More people more often? More people more often? Yes. Does that make the right happy and that it takes pressure off the budget? Yes. So I think even though the nature of a debate is we're supposed to be a little argumentative, but Steve Covey has a great book, The Third Alternative, and the solution's not A or B or some sort of compromise in the middle. It's something else. It's a third alternative. It's not 2 + 2 = 3, where we both get something but lose something. It's 2 + 2 = 6. And as cliche as it is, it's synergy, where we both are willing to be creative enough to think of a solution that we haven't thought of before, combine that in a way that's actually better. So if the state did have a single-payer system, they would do it through direct care, because $1.65 is the absolute best price you can get on that test. And then they could order more tests. And then they would, and so whenever the state is paying for people who can't afford things, they would do it in a very cost-effective way, which is exactly what we do with food stamps. They're saying, look, Dillon's may not be, they're not the most expensive, they may not be the cheapest, but if you want to go to Aldi's or Food for Less or something, or Price Chopper, you can. And you can find the best use of those food stamp dollars. So if it works there, if it's lean, if it's efficient, it provides the services, it's sustainable, then why wouldn't that also work for healthcare?
All right, we've got one last question.
I'm probably going to be a little biased in this, being a family doc and you guys being family docs, but one thing I think you guys agreed upon was that primary care is vastly undervalued by the powers that be, I think. That's like one point of agreement, right?
Yeah.
So,
and he's older.
And we need a radiologist in here.
Yeah. And so my question for Dr. Freeman is, Medicare has existed since 1965, and my math isn't good, but that's over 50 years. And Medicare, I think, through its mechanisms, is largely the institution that set prices for medical care through the AMA, RUC committee, et cetera. I won't bore everyone here. So if we both recognize that Medicare is setting the prices, why haven't they, after 50+ years, recognized this problem of undervaluing primary care? And if we get a single payer that is run by Medicare, how would that be different?
I don't think that single payer solves every problem. And that one of those problems is things like the ruck, the undervalue of primary care. And I think people do deserve some, I'll try to make it really short, but there's a certain pile of dollars, $1,000 to be spent on the health care of all Americans. And we have to say we're going to cost us $5 to pay for this primary care doctor and $75 to pay for this cardiac surgery and, and $27 for a CT scan. So how do we decide how much to pay for these things? Well, actually there's something that called the RUC. It stands for something that doesn't really explain what it is, but it has a bunch of, it's organized by the AMA. It has a bunch of doctors on it, and they say, when we go in here, we take off our hats. We're no longer radiologists who think we should pay a lot for reading mammograms or MRIs. We're no longer cardiologists who think we should pay a lot for, cardiac catheterization. We are just looking at the objective data. But in fact, on that RUC, very small percentage of primary care doctors, very high percentage of high-cost specialists who make these determinations. And then, 95% of time, Medicare decides to go with their recommendations. So that's a flawed system. It's a bad system, and it's a system that is influenced by the fact that not only the doctors, but the hospitals that they work at make a lot of money. You, I recall, were a family medicine resident.
Yes.
You were a family medicine resident, and did you see how much the hospital that you worked at was willing to spend to train more family medicine residents to say, we're going to fund 5 new positions in family medicine because Kansas needs more family doctors? Not true. Because if they funded more cardiology fellows, they could do more cardiac catheterizations and have a higher profit margin. So the pressure is from the institutions. It needs to be changed. It needs to be fixed. And it needs to be fixed whatever system we have of allocating the dollars.
I think it just really makes my point. It's not that, first, the residency program isn't limited by the hospital's greed. It's limited by Medicare. Medicare says exactly how many residency spots they'll fund, and they don't let others. So if we say we'll fund 5, but your hospital wants 10, sorry, Medicare said you could have 5 and no more. So this is what we call a centrally planned economy.
Well, actually,
and it's
that's not completely true, Josh, because KU, for example, was at its Medicare cap, is way above, has many more residents than Medicare pays for. So the KU hospital says, we will fund 10 more residents this year, and none of them will be in family medicine, because that isn't to our advantage. So it's not just Medicare.
But it does make the point that, yes, we need to make primary care valuable. And the way you do that is in a model like this, which is more efficient, and valuable things get funded. So who sets the price for phones? We do. Customers. Who sets the price for apps, for food, for gasoline? You vote with your dollars. Yes, a company sets it, but you decide if that's fair or not. But what we have is 30, 40, 50 doctors working with Medicare, with the government, to set prices. It's not that I think that they're bad people. I think it's an inherently flawed system. I want 250,000 family physicians setting their own prices. And I want 1,000 patients per doctor deciding if that's a value that they appreciate or not. And if I can bring a value more than $50 for you, then you're going to join. Netflix brings a value of more than $13 a month to me, so I purchase the product. But when I save a patient $100 a month on their migraine medicine, because I get for $3, so their $50 a month membership, now I'm saving them $47. They have unlimited primary care access to me and their medicine and $47 in their pocket. So from a business, I've made my value proposition to the patient, but you don't have that option with the government. They set the prices. Even if you lose money at the hospital, Medicare doesn't care. They're going to set that price. You have to make it up by cost shifting to private businesses. But he also kind of leaves out the point that Medicare doesn't just offer you, yes, you're going to die soon, maybe we could do this treatment or not. What they also forget to say is, we may just say, no, we don't pay for your medicine. Sorry, you want this medicine, we think that makes you a fall risk. Yeah, but you're a healthy 67-year-old rancher who's on a horse every day. Medicare won't let you have the medicine you want for your back because it makes you a fall risk. So Medicare is telling patients and limiting patient care. And we know this is true here. We know it's true in Canada. We know it's true in England, where the NIS just said a couple months ago, any patient with a BMI over 30 will not get elective surgery. So it's not even a social justice thing anymore. We sell it initially as a social justice thing, but then the economic reality hits. We only have so much money. So now fat people and smokers don't get care. Well, it was for social justice unless you're fat or unless you smoke, because we're so budget crunched that we're going to not let you have surgeries. So, and anything we deem elective wouldn't necessarily be what would be considered elective here. So we run into certain undeniables when there's a centrally planned economy. So I'd rather have more freedom, less government to run healthcare.
And I get to have the last word, which is fun. Thank you so much for coming out to our last program of the semester. We'll be back in this winter, early winter, fall, spring, there we go, with lots of great programming. And thank you for coming out to the SAB program. I really enjoyed it. Let's give a round of applause for our two speakers.
And thank you, Ms. Moderator.